Well, hi, we're back with video number 3, and in this video we're going to take a close look at edema and ascites. So, just a little bit in review, we looked at the exchange between the capillary and the interstitial spaces and decided that that was where we had fluid exchange that could cause edema. We're going to look specifically at edema in the foot because this is an area that you often see it in the clients that you're assessing right now, and we'll talk about what is going on at a fluid shifting level. So we have veins in the feet, and of course there are capillaries, and we talked about the capillaries being the site of exchange of fluid and of gases and nutrients and waste. We also talked about the fact that if we have increased pressure in the venous system, that we will have increased pressure translated to the capillary system, and we'll have more pushing out pressure or hydrostatic pressure. So in this person, we're going to say we have an elderly person, and they are sitting with their feet down all day long. So as they've got a dependent area, again, we looked and we said the further the area is from the heart, the more effect gravity has on that area. In fact, in the way that there is increased pressure in the fluid column, so pushing back down. Not only do they have that, but they're quite old and they have lost the competency of the valves. Remember, those valves in the vein should be one-way valves. They should allow fluid to go up and not back, up and not back. However, this person's valves have been kind of saggy and limp, and they are not helping with that forward flow. The other thing this little person isn't doing is moving those big calf muscles, so pushing. It's our big calf muscle movements that regularly squeeze those veins and lymph vessels and have that forward flow as long as the valves are competent. Okay, so we've got incompetent valves, we've got pressure just by virtue of gravity, we've got something else. This person is not got great teeth, and they really don't like to chew meat anymore. They don't like other forms of protein, and so in fact their protein intake is very low. They're also resisting all those great supplements that the dietitian's offering them. So in fact, we know that they require large amounts of albumin to sustain that capillary colloid osmotic pressure, where the liver in this elderly patient is not able to have adequate amounts of amino acids to synthesize that plasma protein. So we've got too little colloid osmotic pressure, we've got venous backflow, perhaps we even have lymphatic vessels that are vessels that have inadequate forward flow as well. And so we've got a condition where we've got lots of back pressure and lots of hydrostatic pressure in this capillary. Hence, we're going to weep fluid out at a greater rate. And we are not going to bring as much fluid back in because we've lost a great deal of that pulling osmotic pressure. Okay, so that sets this person up to be losing a lot of fluid into the interstitial area. What is this going to look like? Well, you're going to come along and assess, and you're going to push your finger into this, and you're going to determine that edema is either pitting or non-pitting, meaning that there's no residual dent left when you remove your finger. And if it is pitting, you're going to determine it on a severity scale of +1 to +4, where +1 is minimal and +4 is severe pitting edema. Okay, what's the problem with this? Well, if we have a larger interstitial space, or more fluid caught in that space, we know that we've got a greater area, a greater distance for nutrients to have to move out of the capillary vascular space and to those cells that require nutrition and the removal of waste. So we've increased that distance. We have also we've also created some turgidity in those tissues, and some of you have had the experience of seeing that we end up with serous fluid leaking out, and we've now created, if we've got fluid leaking out of this edematous area, we know darn well we've got the ability for pathogens to also move into that area. So we've got the increased likelihood of infection in that area. It's uncomfortable for the patient. We're holding fluid in that area. Ideally, we should get these people walking, and those legs are heavy and difficult to lift. So a whole combination of factors that tell us that this is not a very good thing. What do we do about it? Well, we can certainly try to diurese the patient and give them a diuretic drug, so we're increasing the outflow. We certainly want to tackle this element of it, though, to try and get them to build better sources of albumin by increasing their nutritional intake of proteins. We tend to put compression stockings on these people. So we put them on while they're in bed. They have had their feet up through the night, and the edema has gone down as much as it possibly can just in being in that position. And what are we doing with those stockings? Well, do you remember us talking about tissue hydrostatic pressure? We're actually increasing the tissue hydrostatic pressure, or in this diagram here, where those tissues are pushing back. So we've got the capillary hydrostatic pressure pushing out, and we've got the tissue hydrostatic pressure helped by the compression of the stocking and pushing it back in. So we're going to get less fluid coming out of these blood vessels, and of course improve the likelihood that we're going to have more fluid in the capillary as it heads to the venous system. Okay, so that is a little snapshot of edema. We're also going to look at this point very briefly at ascites. And ascites is a condition where, again, we have a collection of fluid that has come out of the intravascular space, but this fluid has made its way to a third space, and it's made its way to the abdominal cavity. And if you think back, this is an area where we tend to have some transcellular fluid. We have a little bit of fluid just to lubricate the movements of organs in our abdomen. In this case, though, we get a great deal of fluid caught in that transcellular space, and remember, it is not available to us for metabolic processes and for use in delivering, delivering nutrition and removal of waste and that type of thing. How much fluid are we talking about? Well, a lot. Ascites can be 10 to 20 liters of fluid captured in an abdomen. And how does this happen? Well, again, I've got a little picture here, and this is the portal vein. And so venous system, this is a liver, and this is a cirrhotic liver, meaning that it's an ill liver. It's not a great big open organ that is ready to receive basically all of the blood flow from the intestinal system through the portal vein, and to look after the removal of substances from that blood. Instead, we have a very small, hardened, cirrhotic liver, and it is resistant to blood flow. Okay, so if we take an organ and we shrink it down and we make it very fibrous and hard, it does not let in the blood flow that it should. We have back pressure onto the venous system, and that back pressure is translated eventually to the capillary bed. Okay, so if we can come back to our picture of the capillary bed, we have incredible back pressure here. So all of a sudden we've got great resistance to flow moving out. We've still got flow coming in, and now we've greatly increased the hydrostatic pressure. We've increased it so much so that we're not just leaking fluid out because we're pushing fluid out. We have made gaps in the capillary, the endothelial lining of the capillary, such that we are losing our albumin. Okay? So in this capillary, and of course remember that there's many miles of capillaries that we're talking about in the abdomen, we see that we are weeping out albumin. So we have two problems. We've got a great deal of hydrostatic pressure pushing back, and so the pressure inside this capillary is enhanced. So there's more outward pushing. We also have a great deal of difference in the tissue colloid osmotic pressure. This tissue is now the recipient of many albumin particles, so it has great pulling pressure. So great pushing pressure with great pulling pressure means that we lose an awful lot of fluid into the abdomen. So 10 to 20 liters. If you look at my tummy and think of adding 20 liters to my abdominal area, what we're going to see is a turgid abdomen. Okay, very prominent veins on the abdomen, because we don't just have that pressure in this venous system and the capillaries inside the abdomen. We also see that across the entire venous structure. So we've got some very prominent kind of varicose vein looking veins on the abdomen. We've got, as I said, a turgid abdomen. We're certainly going to hear dulled vowel sounds in this very large abdomen. We will also think about your diaphragm being here and having this big collection, and moms that are pregnant will certainly tell you at the end of pregnancy, before that baby drops, they are starting to have a little bit more trouble breathing in that remember, that diaphragm has to come down into the abdomen and to allow us to expand our lungs. So this person likely has some short of breath enhanced by carrying 20 kilograms more of fluid weight in their abdomen. They're going to have abdominal pain likely, and we can certainly sense that this is not going to be a good situation for the abdominal organs. So increased pressure on the kidneys and the ureters. Okay, so we can certainly be impacting those organs as well. 10% of people with ascites will go on to have a peritonitis. So this is where they develop infection in this area, and if we look at the peritoneal fluid, we would see that it's now cloudy, and this person is going to have, with peritonitis, they are going to have slowing of their bowel sounds, pain, of course, and of course the threat of infection becoming systemic. What do we do about this? Well, when we get to the point that it's interfering with people's ability to breathe and there's risk of infection, we will go in and we will drain this fluid. We want to drain this fluid slowly and methodically. If we were certainly to just put in a catheter and drain it out very quickly, we are going to have sudden expansion of the blood vessels within the abdomen. Remember, they've had some of them have been quite compressed, and if we all of a sudden open those blood vessels up, we will have a lot of the blood flow, or a lot of the blood we've about 5 liters of blood in our body at any time. We will have blood that is engorged blood vessels in this area, and we'll have a shocky situation for that person. So poor perfusion to the vital organs such as the brain and the heart. So we do this in a slow, methodical way. We hope that we see that peritoneal fluid we know that it's going to have a lot of protein in it, so it's going to look perhaps proteinous, we would call it, but it shouldn't be cloudy. If it is, we would of course send a specimen for infection, and we likely send a specimen anyways. The other thing that we can do for this person is that we can put a shunt in this liver. Okay, there is a procedure called a TIPS procedure, and it's a transjugular. Remember that your jugular vein is here. Transjugular intrahepatic portosystem shunt. And so we come in through the jugular vein, and what we do is we put a shunt into the liver between the portal vein, which is here, okay, and we connect it to this vein up here, which is going to head back to the venous system, is part of the venous system and heading back to the heart. So by putting an artificial shunt in here, we give this this blood flow through the portal vein, another opportunity. Yes, it still needs to come into this cirrhotic liver. We still need the liver to do whatever functions it can manage to do. But we also give it a way back to the heart that is through the liver, and a better route than the back pressure route here, or up through the venous system in the esophagus and stomach, where it has likely taken a circuitous route, and we may have veins, tortuous varicose veins or varicosities that are in that esophagus, and of course at risk for rupture. Varicosities in the esophagus and stomach are not great places to have varicosities, because if you look at the function of the esophagus and stomach, we have constant risk of those varicosities being ruptured. Okay, so a good way to have looked at shifts between intravascular space and interstitial spaces, and in this case, the third space. So again, remember that if we've lost this with ascites, this 10 to 20 liters, we've lost that capacity for using that fluid for metabolism, etc. The only other thing I'd like you to mention is, or I'd like to mention to you, is that we will likely treat these people with diuretics. We'll use potassium-sparing diuretics. As we've lost fluid here, the system, the blood system, and consequently our vascular volume has decreased, and our aldosterone system has kicked into gear and starts to pull back sodium. So we've got the condition where we've pulled back sodium. If we're pulling back sodium, we are dumping potassium. Okay, and we've got, usually in these patients, we've got lower potassium than normal, higher sodium than normal. So we restrict their dietary intake of sodium, we give them potassium substances, and we also will put them on a diuretic to try and get rid of some extra fluid. Of course, we can't recoup this fluid very easily. Remember that it's outside now of our capacity to pull it back into the vascular space very easily. That's it for video 3. Thanks very much.